Okay, we're recording. All right, and now we need to go back to the PowerPoint.
That was the first room. Whatever that like.
Let's use the psych thing.
No, because it's on two screens now. Okay, got it. Okay.
Okay, right. Perfect.
How is everybody doing? Can you all hear me in the chat online? We're gonna do this. Well, I know you can hear me.
Thumbs up.
All right, we're gonna do this way because the system in this room is fucked up. Because this is our CSI. Look at this. Look at this shit. Look at that. Look at that. Fucking. That's rough. That's rough. You hate to see it this early in the game. You really do. You really do. For those of you at home, the microphone in this room is literally broken in half and it looks flaccid, and it's just kind of funny, so that's what we're talking about. Just to clue you in on the joke here. All right, welcome back, everyone. Did everyone watch the chest pain lecture? Mm-hmm. Did you like it? Mm-hmm. I don't remember it. So if it was, that's kind of the style that we're going for here, is like chief complaint related breakdowns of what we're trying to do. And it's pretty simple. Hopefully we're only going to cover like the first 3 or 4 steps. And the idea of that is to give you guys enough steps to like not completely lose the plot when we give you scenarios, but there's more to learn. Like this is not exhaustive of everything you need to know for everything. It's just the basics of how to manage each thing. So they're like, when you're going to get to the in-person scenarios and the tutors are going to be like, yeah, but you need to do this too. And you need to do this too. And that's true. But if we want to keep these lectures to an hour, we just don't have time to cover all of that. So it's up to you to get additional knowledge through your in-person scenarios, through outside reading like the Oxford Handbook of Emergency Medicine or whatever other resources we provide you. And that's how this works. Okay. All right. Great. As per the usual, my bullet point is broken apparently. The disclaimer, I'm going to say a bunch of shit. Hopefully it's useful to you in Sim Wars. It may or may not be useful to you in real life, and people might get mad at you for repeating the things that I say if you say them to our CSI people. So, I don't know. It's up to you to be a judge of how that's going to work, okay? All right, so we're going to talk shortness of breath. One of the most common complaints, presentations to the emergency department, especially this time of year. Shortness of breath is a pretty big one, and it can be a lot of different things. You see some grayed out stuff up there. There's a few. There's a lot more than that, but we're going to talk about kind of the basics here. So the first one that I don't want you guys to forget is acute coronary syndrome. So ACS, MI, everything to do with that. We talked about that stuff last week, so we should be pretty up on that. But like, I've seen many a patient come in saying, I'm short of breath. Oh, do you have any chest pain? No. Massive fucking STEMI, right? So like, don't discount it, okay? That's the big one. So then kind of as a knock onto that, congestive heart failure, right? It's another heart problem. Normally when we get the shortness of breath in the emergency department with your congestive heart failure, these are like the acutely sick, like right-sided MIs with congestive heart failure or some other like instigating factor that causes that CHF. It's not normally the chronic person. Now, that's for Sim Wars. In real life, the chronic people show up to the ED all the time with their chronic complaints, but you don't tend to see that in Sim Wars all that much, okay? So CHF is another one on there. PE, it's a classic. All right, we all should know about PE at this point. It's one of our CSI's favorite things to teach about. It's because it's got some really easy like scoring criteria and rule-out criteria that we need to know. And yeah, it's pretty classic. And the pathology is really easy to understand, so they like to teach you guys that a lot. All right. Asthma is another one. Asthma, we can lump asthma in with like our reactive airway diseases, things like COPD, any other sort of reactive airway disease. But those kind of tend to go together and tend to be treated in much the same fashion. And we'll toss a little pneumonia on there too. This covers your pneumonia, but also covers your things like your COVID, your viral pneumonias, and we want to keep an eye on those as well. All right, now on to the rarer causes. Pleural effusion, okay? Normally it doesn't happen by itself. Normally requires some other stuff, but we'll talk a little bit about pleural effusion. Spontaneous pneumothorax, another pretty rare one, but does happen, okay? One to know. And remember, we're not talking about trauma in these. Trauma is a separate block of lectures. So we're just talking about like medical problems here. So spontaneous pneumo, it's on there. Do we see it all that often in real life? Not really. It does happen. Do you see it in Sim Wars? Yes, because it's one of those things that has a pretty easy like set of diagnostic criteria and tests your physical exam skills pretty early on in the scenario. So you can really easily see where the team's going to go with that complaint as soon as it happens, right? So if you miss that spontaneous pneumo, That's bad. Okay. All right. Primary hyperventilation. This is your things like your panic attacks, right? We don't talk about these as much. These don't tend to show up in sim wars as much. However, something to be considering. Someone comes in, is breathing really fast, no other complaints, we're not sure why they're breathing really fast. Don't discount maybe just trying to talk to them and get their breathing to slow down by saying, hey, slow down your breathing. All right. Respiratory compensation for some other conditions. So can someone throw me an example of this? Come on. You're second year medical students. Okay, altitude sickness, not bad.
Any sort of like CKD.
Okay, chronic kidney disease, and metabolic acidosis. Kussmaul respirations because of diabetic ketoacidosis is a big one, right? So that can be a pretty common one that comes in and can pop up in sim wars a lot. Person comes in, is breathing super rapid, super deep. They're like, oh my God, it's so hard for me to breathe. Are you nauseous? Oh yeah, I feel sick. I've been vomiting. Oh, all of a sudden now it's not really a respiratory scenario, it's a DKA scenario, right? So one to not discount entirely. And then our little COVID-19 toss it on there just to keep ourselves relevant, okay? All right, good stuff. All right, so we always use our same shit. We always use OPQRST or Socrates if you feel like a dork. We always use sample, right? So we've talked about this stuff a bunch, but I don't want you guys to forget it. These are at the head of every lecture. We talk about OPQRST, we talk about sample. This is how we actually figure out what's wrong with the patient. Like, fuck a chest x-ray, fuck labs. This is how you figure out what's going on. When did it start? Was it suddenly or gradually? If it's sudden, we have already narrowed our band down to like 3 things, right? We've got PE, we've got spontaneous pneumothorax. Like, what else causes sudden onset respiratory distress? Maybe your primary hyperventilation, right? There's not much. So you get that answer, and all of a sudden your band gets narrowed down pretty significantly. Provocation, palliation, shortness of breath, things that make it better or worse can be super useful. In most of these cases, they're going to be like nothing makes it better or worse. But if we have like maybe sitting up makes it better, then all of a sudden you're starting to think about like fluid overload, CHF. Now you're starting to get answers, right? Quality, what does it feel like? This is less relevant for shortness of breath, but it can still be relevant, right? Because there's a lot of different ways you can feel short of breath. It can be like, oh, it's hard to catch my breath versus it hurts to breathe, right? And people tend to describe both of those things as like, oh, I'm short of breath, right? So narrowing that down, like, what does it actually feel like? Is it hard to breathe? Is it you feel like you're not getting enough air? Is it your chest tight? That type of thing. Radiation, not super relevant with shortness of breath. Doesn't really radiate anywhere per se. Severity is a really good one, especially in patients that have these kind of like acute on chronic conditions like asthma, COPD. You know, is this bad? Is it as bad as it's ever been? How bad has it been? Have you had to be intubated? Things like that, right? Time, does it come and go? Is it constant? That can be super useful for our, again, back to our like CHF stuff. Or our asthma stuff, oh, it's worse at night, whatever. And then we got our sample, also super relevant. Signs, symptoms, allergies, hugely relevant for shortness of breath, right? Medications, past medical history, again, like people don't come into the real emergency department in the real world with new shit, right? You're never like, oh man, I'm going to diagnose this person with like this crazy new disease. It's going to be like, oh, this is my 19th COPD exacerbation. Great. Like... Nothing is interesting. All right, last row intake. Less relevant, starting to go down the allergic reaction line there, and events. Okay, so our secondary survey from our respiratory perspective, so our respiratory exam, remember this from last year, airway, breathing, circulation, inspection, palpation, auscultation, percussion. Super simple stuff. Check the airway, make sure it's clear, look, listen, feel. Listen to the chest wall with your stethoscope. We want to talk about things like getting a pH from our ABG or VBG, which is super useful. We want that gas in these cases. And then we talk about our chest x-ray, a few other things too, but those are the big ones that we really want to make sure we don't miss. And then anytime we have a respiratory complaint, we're also doing a cardiovascular workup in sim wars, right? So someone comes in with shortness of breath, like I said, I've seen a lot of people come in with like number one complaint, shortness of breath, problem, ends up being a STEMI. So we're doing our full cardiovascular workup when we have respiratory patients as well. Now, if it's a 19-year-old that comes in with a history of asthma, that has wheezing and is clearly having an asthma attack, are we going to do troponin? Maybe not. Are you going to get that simple-ass scenario in the SimWars competition? Never, right? So do your cardiovascular assessment. All right, so let's talk about the common causes. First one's ACS. We talked about this last week. Was this unclear at all? Does everybody understand the basic management of our acute coronary syndrome, our like chest pain patient, crushing chest pain patient shows up to the emergency department? We can break this down into a bunch of different categories, but at the end of the day, it's pretty much the same management no matter what you're doing. So these tend to be characterized by our constant pain, central pain, crushing pain. Not always, right? Can be other shit. Can be your shortness of breath. Can be, like weird, queasy abdominal pain. Can be, I'm sweating profusely and I have no idea why. Look at your patient. Are they somebody that looks like they're having a heart attack? Do they look like they're in the age bracket and the sickness level to be having a heart attack? If they are, do your job. We tend to associate these with our shortness of breath, diaphoresis, which again, profuse sweating for those of you that don't know, and nausea. Who are our patients that present with atypical MI presentations? Women.
Diabetics.
Women. Diabetics.
Elderly.
Older people. Yeah, those are kind of our big three. That doesn't mean that a 35-year-old guy cannot do that, right? But tends to be more often than not women, more often than not folks with diabetes because they have weird fucking neuropathies that mess with all their nerve endings. And more often than not, the older you get, the weirder your presentations tend to be. So that's our bracket for atypical MI. That does not mean that our overweight 35-year-old man can't have an atypical MI, right? There are no rules. There are only guidelines. All right. That's basically it. Congestive heart failure. This is a big one. This is a huge one. This can be kind of lumped in with our chest pain, but in reality, this is something we really want to talk about. So congestive heart failure is cardiogenic pulmonary edema. What do we mean by that?
It's caused by the heart.
Fluid in the lungs caused by something wrong with the heart. That's simple, right? So something's happening with the heart. It's backing up that fluid into the lungs, right? In a lot of cases, these patients can be managed by keeping their fluid balance low, right? We take fluid off of these patients, diurese them, and that way, by reducing the fluid load on the heart, we reduce that congestion. Does that mean that the heart is fixed? No, it just means we've reduced the burden on the heart such that it's not backing up as much fluid, right? So, we need to be careful because if they end up fluid overloaded, they're going to go right back into the same situation. So this tends to be left heart failure. It can be right heart failure. It depends on where stuff goes. So how does that work, right? If my left side of my heart fails, where does the fluid back up? Goes in the lungs, right? Right side of the heart fails? Periphery. Great. So in our shortness of breath lecture, we're talking left-sided heart failure. Fluid backs up into the lungs, right? In reality, is it that simple? No. In reality, it's normally a crossover. There's normally both. You can have whatever you want. You can have, like, all sorts of weird shit. So we're going to end up with fluid in the lungs for whatever reason. We're not cardiologists, right? But we're going to end up with fluid in the lungs for whatever reason. What can cause congestive heart failure? Okay, yeah, you picked the 1% there. Pick common things are common, guys. What can cause congestive heart failure?
Valve issues.
So yeah, valvular problems, right? Valvular pathologies.
Previous MI.
So yeah, any sort of previous MI that's resulting in like myocardial dysfunction.
Cardiomyopathies.
Yeah, any sort of cardiomyopathies.
You get pericarditis.
Yeah, you could get one of those. That tends to be that you're back down to your sort of more rare stuff, but it tends to be our structural heart problems, right? So that whether that's an inborn structural heart problem or an attained structural heart problem, whether it's a wall dysfunction from a prior MI, maybe it's dilated cardiomyopathy, maybe it's HOCM, who knows, right? But at the end of the day, it tends to be a structural problem with the heart. But yeah, you can have all sorts of wacky shit, right? You can have all sorts of crazy stuff that can cause it. So what are these characterized by? What do these patients complain about? They come into the ER, something's wrong with them. What do they say? I'm short of breath, right? I can't breathe. I can't catch my breath. What else?
Fatigue.
Sometimes fatigue, yeah. So I feel more tired than usual.
Gotta sit up.
Have to sit up, right? Hard to lay down. Shortness of breath tends to get worse when laying down.
Swelling in the ankles.
Can be, yeah. So they're really, really common, and the whole like left versus right, lungs versus legs thing. Yeah. Normally, if you're CHF, you're gonna end up with some peripheral edema for sure. That's not normally the reason that they present to the emergency department, but you'll see it on your physical exam, right?
Palpitations.
Can be.
Can't sleep.
Yeah, so can't sleep. That goes with the like hands in hand with like tough laying down stuff. Adara's not monitoring the chat. I should probably be monitoring the chat. Let me look over here. Ooh, yeah, can't sleep. Header said it. Good stuff. Yeah, so that's a pretty good run. So cough, right? What kind of cough?
Non-productive.
Non-productive or later stage, sometimes productive of like not mucus. So productive of like frothy sputum. That's just exudated blood plasma, right? Or transitated blood plasma, whatever, it doesn't matter. So dyspnea, distress, cough, It tends to be in their history, right? We're going to see that stuff in their history. Fine crackles at the bases of the lungs, normally, right? Think about when we talk about crackles and we're hearing those like popping and crackling, that's either alveoli opening or it's bubbles passing through fluid. So our fine crackles, the finer the crackles are, the less viscous that fluid is, the thinner that fluid is. So our crackles in CHF are caused by air passing through fine fluid. Water, functionally water, basically. So it's going to be finer crackles. Where when we talk about the coarse crackles in something like a pneumonia, right, that's bubbles passing through garbage. So it's right. Okay, good. ECG findings. What are ECG findings in congestive heart failure?
Is it weird? Is it like changes everywhere and never leads?
It's going to be the thing that caused the congestive heart failure, right? So there's no like specific changes. There are like things that you can look for like right ventricular strain, whatever. But you maybe will see like an old MI, some sort of pathologic ST segment changes from an old MI. Maybe the instigating factor is a new MI, right? Maybe we see that ventricular hypertrophy that can come with our cardiomyopathies, right? We're not going to see. There's not like one specific like this is what you look for CHF, but you'll probably see some bullshit, whatever it may be, right? BNP. Anybody good with BNP?
Elevated.
What does it stand for?
Brain
Brain
natural.
Yeah, brain natriuretic peptide. Obviously, brain natriuretic peptide is associated with the heart. So that's super simple. We're all on the same page there. So when we say BNP, what do we think about that?
I see a raise when there's deathly cardiac tissues, or not deathly. Is it not deathly? Something about cardiac
Dilation.
tissues.
So overstretching cardiac tissues, right? And specifically BNP is associated with ventricular strain, right? Again, it's not as simple as just always, but like BNP is associated with normally ventricular strain. What's the one that's associated with atrial strain? Yeah, ANP, right? So you got your atria and your brain, obviously, in your heart. That's how that works. Chest X-ray findings?
Cardiomegaly.
Maybe, yeah. Could be cardiomegaly if we're talking about maybe one of these like dilated or hypertrophic cardiomyopathies that are causing CHF.
Yeah, pulmonary edema.
That's the real one. So pulmonary edema. So what do we see in pulmonary edema on a chest X-ray?
So you see like consolidation. Kind of like.
You don't necessarily see consolidation.
Is it the coast to like the angle that's not?
I'm not gonna fucking. I'm asking you. You look at it. You look at a chest X-ray. What are you looking for?
Diaphragm's like blended.
Okay, not necessarily. Could be, not necessarily. You see fucking pulmonary edema, right? You see all these little, like, fluffy white infiltrates in both sides of the lungs, not in just one, right? Because you're not going to get, like, a lobar congestive heart failure. So it's going to kind of be everywhere. It's going to be worse lower down than higher up, right? You hear about things like curly bee lines and shit like that. I don't care about that shit. Look at this, right? It's fluffy all the way, all over down here. It's filled with white stuff. It's not up here, right? That's pulmonary edema. Maybe not CHF, but it's pulmonary edema. Is it pneumonia? Could be like maybe like a wacky COVID pneumonia, but it's not like normal pneumonia. It's not like our lobar pneumonia because there's no like specific lobar consolidation. It's just kind of everywhere, right? That's what we're talking about. This simple, right? Looks gross. Well, that was weird. Looks gross. All right, cool. So how do we treat CHF? Okay. Maybe let's go fucking take 15% off, or let's start with the basics.
Fix the problem.
Okay, so
Like a valve issue.
what if we can't fix the problem? That's also not the basics. Doing a valve replacement in the emergency department, very much not the basics.
Management with oxygen.
So yeah, there we go. Now we're starting to think about the easy stuff. So manage with oxygen, high flow oxygen, good stuff. Obviously, maybe not necessary. Maybe they're satting 96%, don't need high flow oxygen, whatever. But in a situation where they're low oxygen, high flow oxygen, we can use CPAP or BiPAP, preferably BiPAP. What does that do for us?
Also removes carbon dioxide.
Removes carbon dioxide, but also with regards to the fluid.
Oh.
It goes down into the fucking and pushes the fluid back in. It's like, get out of here. It shoves it back into the blood vessels, right? Because the reason the fluid's getting out is because the pressure in the circuit's too high. So it's leaking through the walls into the lungs. If you increase the pressure in the lungs, all of a sudden the fluid will leave. It's really dummy monkey level stuff there. Like that's
That's how I want to be taught.
Yeah, okay. Good. That's monkey level stuff, but that's it. We use furosemide, that's our diuretic, right? That's our go-to diuretic, especially in these acute cases. That's Lasix.
Yeah.
It's a loop diuretic. Everybody on the same page. Takes the fluid out. They pee everywhere. It's great.
How quick was it packed if you were to give to somebody?
Pretty fucking quick, dude. I like 30 minutes. I've given somebody Lasix in the back of an ambulance. By the time we got to the hospital, I need to piss real fucking bad. So it's pretty quick. I don't know. There's probably a number out there that's this is the onset of action. Fucking fast.
It really helps in the situation.
It's not gonna if they're actively decompensating. It's not going to save them. Okay, so we gotta do the BiPAP shit too. Okay, but it is quicker than you think it is. They'll be peeing pretty quick. We want to watch that. If they start peeing, we want to make sure that we're monitoring their fluid output. Right, we want to care about that because we don't want to over diurese people because we can make them sick pretty easily. This is a thing that happened a lot in EMS back in the day where paramedics had we had Lasix in the protocols for CHF, and we didn't do enough good solid teaching about how to differentiate CHF from pneumonia, and then a few dummies diuresed people with pneumonia and then made them sicker because now they're both ill and dehydrated, right? Don't fucking do that. It's pretty simple to figure out the difference between the two things, right?
Come to that conclusion, what they look at.
Stupid. So the missing basic stuff. So you get a list of interventions that you can do, and you feel like you should do them. So you're looking at a patient with pneumonia. You don't have anything you can do for them aside from give them oxygen, but you have this other thing from this other protocol, and you tend to tunnel vision to things that lead you to action rather than inaction. And oops, right? So don't do that. All right, and then treat the cause. Now we're talking about okay, we have an MI that's an acute MI that's causing this CHF. Well, now we can go to cath, right? Or now we can do whatever. Refer the patient for a valve replacement if that's the thing that's happening. It's probably not going to be Simwars level stuff, but there you go, right? So this is our protocol. This is a pre-hospital protocol in the state of Pennsylvania for our CHF patients. You'll notice one other thing up here that I just want to point out to you real quick. This is kind of a crisis scenario thing, but I'm going to hit you with it anyway because it does come up. If we are mad, short of breath, super congestive heart failure, and we're just filled with fluid, we maybe don't have BiPAP or we're working on getting BiPAP, we can use sublingual nitroglycerin to open up the vessels, give us more space in the vessels while we wait to get the whole situation squared away, right? So we can do this. It's not super common. You don't see it in hospitals as much, but it is an out that you can use if you get in trouble. We used to do greater than 180 systolic 3 sprays, greater than 152 sprays, greater than 121 spray, right? That's just a thing. There's no science behind it. There probably is science behind it, but it's not a protocol. It's just what we used to do, right? So you can administer your nitroglycerin there. We also have here something to consider. Some of these patients have comorbidities, right? Maybe they're CHF and COPD. A great irritant in the lungs is the presence of fluid, so one thing can very easily beget the other. So don't completely write off your asthma, COPD, bronchospasm either. If you're listening to this patient, they're fine crackles in the bases and then wheezing in the upper fields, it's completely reasonable to get them on BiPAP, but also flow some salbutamol through that BiPAP, right? Because the two things are happening at once, basically. All right, good stuff. PE. Where does it come from? Usually DVTs, right? It comes from DVTs. DVTs thrombosis. It leaves the legs and goes to the lungs, okay? What do these patients complain of? Shortness of breath. Describe the shortness of breath to me.
Pain when breathe pleuritic.
Okay, pleuritic pain. Sometimes not pain, sometimes just shortness of breath, but pleuritic pain is a really common finding. Sometimes pinpoint pain, so they'll be able to point to a place and say it hurts here, which kind of differentiates it from our MI sort of general chest pain. What else? Onset? Sudden onset. That's the big one. So sudden onset, shortness of breath, plus or minus pleuritic chest pain. What else can they have? So DVT symptoms, right? So you can have unilateral leg swelling.
History of mobilization.
Good history. So history of risk factors. Great. So those are risk factors. Contraceptives, what else?
Mobilization.
So long-term immobilization, so whether that be surgery or
Long-term plane rides.
yeah, work from home, sitting in front of the desk all day, long-haul flight, whatever. OCP use, smoking, the big one, right?
Female.
Yeah. OCP use, so
Just talking
what else? So yeah, if they have a coagulopathy that makes them hypercoagulable, a little bit of a rarer one, but definitely one to consider.
Malignancies.
Yeah, so malignancies, that's kind of the other big one. So we're thinking about the things that are in what scoring system? Well score, good stuff. Okay, so shortness of breath, pleuritic chest pain, risk factors. The big one you'll see is periods of inactivity. Hemoptysis is a good one to remember because it's one of those things that happens fairly rarely, even in PE patients. But if you have a patient with hemoptysis, you need to rule out PE. Okay? And then signs and symptoms of DVT. So pulmonary symptoms, hemoptysis, maybe our DVT symptoms, so pain in calf or thigh. I don't know if I agree with dull chest pain, but it tends to be a local chest pain, whether it's dull or sharp. Coughing, sudden shortness of breath is the big one. So the onset is kind of the clue there. I come in with sudden shortness of breath. These patients, when they're in SIMWARs, they tend to be fucking home runs. They'll be like, oh man, I just came back from Sydney and now I'm short of breath. And you're like, well, fucking okay. Like, but you never know. All right, so what do we do for our diagnostics in PE? Say again? What do we do? So, great thought. Not the first thing I'm looking for. Patient comes in. I'm suddenly short of breath. What do we do for our diagnostics? What do you care about? So, yeah, we care about gases. We care about pulse oximetry. That's the big one, right? So, pulse ox in this case is going to tell us how bad is this PE, right? Care about end-tidal capnography. That'll give us an up-to-the-minute monitoring of our CO2 output. Bloods, FBC. There's D-dimer here. There's a question mark after D-dimer. Why? D-dimer's a fucked up lab. Because all it does for you is it tells you that there are clots somewhere in the body. So if you get a D-dimer and it's positive, now you've bought yourself a CT pulmonary angiogram, right? Which you don't necessarily need in a lot of cases. So D-dimer tends to be that we're going to use this to rule out PE in a situation where we are pretty sure that it's not there, but we have to do something to make sure it's not, right? And then it gives you a baffle before you send every patient to CTPA. If a patient comes in with a home run PE history, it doesn't matter what their dimer is, they need a CT pulmonary angiogram anyway. So don't get too caught up in dimer there, okay? ECG, what is the most common ECG finding in pulmonary embolism? This is a step one question.
S1, Q3.
Fuck you. What's the most common ECG finding in pulmonary embolism? Someone in the chat online, give me a fucking most common ECG finding in pulmonary embolism. Sinus tachycardia. All right, that's it. S1Q3T3 is a fucking great thing to know. It's great. That's why it's up here, because this is the one that you'll forget about. But the most common ECG finding in pulmonary embolism is sinus tachycardia. Just a heart rate greater than 100. That's it. Okay? So you get your ECG, you're looking for that S1Q3T3. It's sinus at a rate of 115. You're like, I don't see any S1Q3T3. We're good. No, you're not. All right. What do we have here? You guys have seen this before. Yeah. Okay, great. So the Wells score is fucking stupid because it's like, do you think they have a DVT? That's like, do you think they have a PE? Like, fucking whatever. Okay. So what else can we use aside from the Wells score or the I'm just gonna give you the answer. What else can we use aside from the Wells score in PE? Specifically for rule out, right? Because ruling in PE is easy. It's like, do they look like they have a PE? All right, we're gonna fucking do the workup, right? But to rule out, you have a patient that's on the borderline. Maybe they're a female smoker with oral contraceptive use that's a little bit short of breath.
Negative D-dimer, you check it out.
Presenting the E. So negative D-dimer, you can check it out. I'm still not a huge fan of D-dimer, but negative D-dimer. Has anybody ever heard of PERC? Ooh, okay, this is new knowledge. Does everybody have MD Calc on their phones?
What?
MD Calc. You should get MD Calc. So there's this nice scoring system called the PERC criteria, Pulmonary Embolism Rule Out Criteria, PERC. Okay? So this is your nice, useful way to like not have to get a D-dimer in a 35-year-old female that presents to the emergency department with shortness of breath and no other symptoms, right? This is your like, we can use this criteria to rule them out so we don't have to get that lab and we can say, oh no, they have a viral respiratory tract infection, they have pneumonia, whatever. Okay, so get PERC. It's pretty simple. It's really, really simple stuff. Age less than 50, right? Heart rate less than 100 because sinus tachycardia is the most common ECG finding in PE. O2 stat less than 95%. We don't want that. If it's less than 95%, obviously we need to work them up for PE. Unilateral leg swelling, hemoptysis, recent surgery, prior PE or DVT, and OCPs, right? So any +1 on that tells you no, you have to do a D-dimer at least. But if they get a 0 on that scoring system, they're perked out. They don't need that PE workup. Okay, so that's a kind of relatively new one. You'll see it in use out there in the world. All right, but Wells score is a good one to remember, especially for our CSI. They have a hard one for the Wells score for some reason. Okay, this is Wells score for DVT. Wells score for P is like pretty much the same thing. Okay, chest X-ray, normal findings normally. Very rarely do you see chest X-ray changes, especially in the early stages of PE. Our CT pulmonary angiogram is the diagnostic test of choice. If we are concerned that a patient is having a PE, they have the clinical signs and symptoms of a PE, you don't need to wait for the D-dimer, order the CTPA, okay? Get him to CTPA, then you're gonna see that fucking big fuck off clot in there, and maybe you're not, right? And then our VQ scan is a little bit dated. Why might we do a VQ scan over a CTPA? Does everybody know what a VQ scan is? So you know how B stands for brain? Q stands for perfusion. All right. So a VQ scan is a ventilation perfusion scan. All right. It used to be the way to diagnose PE before we developed and got good at CTPA. So we might use that in a person that can't get IV contrast for whatever reason, right?
Is it like in terms of how long it takes to get? Is it like
It'll be way fucking harder to get a VQ scan. It'll be way harder to get a VQ scan. I don't know how you would even do that, but like that's the thing, right? Yeah. So this is like you use, and I don't know this off the top of my head. This is Wikipedia right here. All right, so don't pretend like I'm knowing stuff. All right, so this basically you don't have to use CT pulmonary angiogram, right? You're doing an angiography, so you're pushing IV contrast. You're looking at the contrast dye and it flowing through the pulmonary arteries, right? So VQ scan, you're going to use scintigraphy instead, and they're going to inhale, like basically inhale a marked isotope, and then you're going to see whether that isotope is getting into the lungs and then also is it getting uptaked into the blood, right? Does that make sense? So you're not going to see that very often, but just throw it out there. If you hear somebody say VQ scan, that's what that is, all right? Great. So how do we treat PE? Little flow chart here, pretty simple, all right? So we're treating PE. We can treat PE in a few different ways. We can absolutely treat like minor PEs can be treated outpatient, okay? Do we tend to see things that get discharged in sim wars? Very rarely. We tend to see like big emergencies, right? So we're not normally going to get our minor PE, but let's say we do. Patient comes in. Are they hemodynamically unstable? No. Unstable, whatever. No. Move on down. Are we worried about a comorbidity? Do we have any dysfunction? No, we're low risk. Home treatment. What's our home treatment? Yeah, what kind? Anybody know? That's fine. Good stuff. All right. What else? Oh, they didn't hear that. DOAC, for those online. Home treatment. You're not going to see people discharged home with anything in sim wars, but there you go. All right, so our more dangerous PE, we're going to keep them in the hospital, obviously, right? Oxygen is huge. We want to supplement their oxygen. This is a high flow oxygen is okay situation. Right? These patients don't need like nasal cannula oxygen. You just give them high flow oxygen. We can thrombolyse them, right? If we're in a situation where we're like into these very dangerous areas, we do rescue reperfusion for those patients. We can thrombolyse them. There are cases that we need to go instead to thrombectomy, right? Which would be our very, very severe cases or patients that can't get thrombolysis for whatever reason, right? Pretty simple. High risk. Reperfusion treatment.
So if, let's say, in a scenario, you're thinking like, okay, plan ahead for this patient. What's the things we're looking for when we're thinking, okay, I should call up surgery to get them for all this?
Okay, so Jayden's question for those online, what are we thinking about when we're starting to think like destination for this patient? How are we going to treat them definitively? The answer to that question is, are they hemodynamically stable or unstable, right? So are we, sat at 93%, heart rate of 110, normal blood pressure? Or are we sat of 90, heart rate of 130, and a blood pressure of 90/40, right? In that second situation, that patient is hemodynamically unstable. They're automatically at the highest risk criteria for PE, and they automatically go for reperfusion treatment. If the service is available, that means thrombectomy. If not, that means potentially a rescue thrombolysis, okay? You're never, very, very rarely are you going to see people in sim wars that are like the low risk category. They're almost always going to be that high risk crisis scenario because that's what they're testing. So be ready for that situation. Cool? All right. Talk asthma real quick.
Oh wait, can I have a question?
Yeah, go.
So in the previous case, once you figure out like they're thermodynamically unstable, then all you have to do is just make the relevant calls. Like the runner just has to do that, or
You got a few other things you need to do. So we need to support them hemodynamically, right? So that means oxygen. That also means potentially fluid resuscitation or transfusion, depending on the situation. And then we can also start heparin, right?
okay.
So we
And
can.
we need to. Sorry.
Go ahead.
I was just gonna ask, like, do we need to know, like, I guess the amount of heparin?
Not yet.
Because we're everything we. Okay.
Not yet. We'll teach you that in scenarios.
Dude, push.
Okay.
If we give them a TPA, isn't that going to put them at a really high risk of bleeds?
Yeah.
So, both. Okay.
Yeah. All right, let's talk asthma. Asthma is chronic reactive airway disease, right? Can be caused by any fucking thing you want, right? It could be anything, could be nothing. What are our asthma characteristics going to be? What is a patient with asthma going to present when they're looking at their history and their physical exam?
Wheezes.
So shortness of breath with wheeze is really common. Do they tend to have chest pain? Nope. Tend to have chest tightness? Yes. What else?
History.
Yep, history. So what is in there? Do they have a history of asthma? There's no pediatrics in SimWars, so odds are your asthma patients will have a history of asthma, right? Wheeze, what about percussion? I very rarely talk about percussion, so it's fine. So are patients with asthma going to have dullness to percussion? Resonance to percussion?
Normal percussion?
Maybe normal, maybe a little bit more resonant than normal because we're air trapping, right? Think about asthma. Asthma is an obstructive airway problem, so we're trapping air in the alveoli. We're not getting air in, so we tend to get puffed up. We're having more trouble exhaling than inhaling is what we're going for there.
So in a similar scenario, would you, if we suspect asthma, also want us to palpate, or is that like a waste of time? Let's.
I'd say if you're pretty sure, you're fine. Now, there's going to be a situation here that it's always going to come up. You're going to get to like minute 6. You're going to have most of the balls rolling. Things are going to be happening. You're waiting for labs, maybe waiting for x-ray. People are sitting around doing nothing. At that point, you can jump in with your full RCSI respiratory exam, OSCE, and be like, I'm going to inspect, palpate, auscultate, and percuss. And then you look like a real great guy. All right? But in the first 3 minutes, probably not. All right, diagnostics for asthma, same general thing, pulse ox and tidal, ABG, chest x-ray. What are we going to see on chest x-ray?
Increased air track.
Maybe see hyperinflation, pulmonary function tests. Pulmonary function tests not going to happen in a SimWars scenario. You're not going to be like, hey, blow into this for me right now while you're dying on the table, okay? So, but that's how we're going to end up diagnosing this long term, right? So how do we treat asthma? We're going to treat with high flow O2. We can move on to CPAP, but I really prefer BiPAP in obstructive cases because CPAP is just constant pressure drive. It's not actually going to let air come back out. So we'd much rather, if we're going to use any sort of positive pressure ventilation, much rather use BiPAP. Get them sat up. You'll be floored at the number of times I've rocked up to a nursing home as a paramedic and they've been like, this patient's acutely short of breath, that's fucked up, and they're like laying down in bed like dying of whatever. If you sit them up, you fix them, okay? So sit them up. The same with every shortness of breath case, okay? So we can do nebulized salbutamol. This is our kind of go-to first pick, right? 5 milligrams. That's 2 packets, 2 sachets, as they say here, of salbutamol. And I always add ipratropium even just at the beginning. Like RCSI's got this like thing where it's like, give salbutamol, and then if it doesn't work, give ipratropium. Just mix them together. It's called Duoneb. They sell it like in packets. Mix them together and send it. 0.5 milligrams of ipratropium in there and just get it going. Here's a little protocol for you. You'll see this everywhere. It's the same general stuff. Mag sulfate is another pick we can go to. Let's look here. So if we're looking at this flowchart for the guys online, severe respiratory distress, no. Nebulized bronchodilator. If we go to no, this is when you can be like, here is an inhaler. Take this, right? As opposed to wasting your nice nebs. And then fix them, right? Severe respiratory distress, yes. Coming down here, we don't care about pediatrics, only adult. Nebulized bronchodilator. Albuterol 2.5 mixed with ipratropium. So albuterol 2.5 mixed with 0.5 of ipratropium. That gets you a Duoneb, which is 3 milligrams of total drug. You can do that twice. That's what I do. You might, RCSIs do this first, then that. That's fine. Keep moving on down the line. We're looking at a steroid. Could be methylpred. Could be prednisone is the common one here. That's kind of the next step. As we go deeper, then we think about mag sulfate, right? Our IV mag sulfate. This is grams, 2 grams over 20 minutes. And we can go deeper than that. This caused some fucking heat last year. This did. When I was up here and I said, if a patient is dying of asthma and you've wasted everything else, give them IM epinephrine. And people were like, you can't do that. That's crazy. And it's not really in any of the protocols, but it does work. So I would not recommend pulling that out as your first, second, third, or fourth line. And I wouldn't recommend doing it during sim wars. But if you're out there in a community emergency department and someone is dying and you've done everything else, stab them with an EpiPen. What's up?
You have to be wearing your cowboy hat when you do that.
100%. Always. Never not wearing the cowboy hat. All right.
So it helps because sometimes it might be an allergic reaction that's been mistaken by an asthma attack.
So smack that shit. Don't always do that. So the RCSI protocol that you'll hear is you start with your nebulized salbutamol, right? Which is great. You can add your ipratropium bromide to that a little bit down the line. After you've done one neb and it's not working, do a second neb, add your ipratropium. Go ahead with your corticosteroid. The thing about the corticosteroids is they're going to help longer term, but they're not going to turn your patient around in like 20 minutes, right? So you give your prednisone. You can move on to your mag sulfate drip. Then you start to get into the weird space of thinking about things like IV salbutamol, aminophylline, theophylline, and a few other like esoteric ones that they have on their list of stuff to do. Long story short, follow the protocols. Start with your salbutamol. Move on to your corticosteroid. See how things go. What's up?
All right, so you mentioned a couple times now that CPAP, BiPAP, do we get access to that in some way?
Yes.
Sweet.
And BiPAP almost always. So CPAP is way out of vogue now and tends to only be like on backwoods ambulances. In hospitals, you'll normally see BiPAP. So use BiPAP if it's available to you in pretty much every case.
There's something that I think has come up in RCSI sometimes. I don't know how it plays in an emergency situation where you see somebody asthmatic and you expect them to hyperventilate, so you see their CO2 is quite low. But then when you see it start to climb, you start worrying.
Yeah.
They're tiring out. How does that play into an emergency situation, or do you just follow the protocol?
Man over here has basically explained to us the difference between type 1 and type 2 respiratory failure, right? So, type 1 respiratory failure, right? Type 1 respiratory failure, I want you guys to kind of think of that as compensating respiratory failure, right? So that is, we are hypoxic, we're breathing fast to try to make up for hypoxia, and therefore we are blowing off our CO2. We are hypocapnic, right? We're breathing fast, but there's enough gas exchange going on in the lungs that we're actually eliminating carbon dioxide well. So that is type 1. That's our early respiratory failure. As we move to type 2 respiratory failure, we start to slow down, we start to tire out, and we start to increase CO2 in the blood because we are now not exchanging gas at the alveolar level, right? That is super relevant to these situations. What that does is it just determines how much you poop your pants, right? Because if you have a patient comes in acutely in distress, but in type 1 respiratory failure, you're not going to be like, oh, they're in type 1 respiratory failure. Like, they'll be fine. We'll just give them the first thing, right? We still treat them. We treat them based on their symptoms. However, if you get that gas and you're like, they're in type 2 respiratory failure, all of a sudden now that decision to put them on BiPAP earlier, right? Are we maybe getting ready to intubate this patient? Are we preparing for that eventuality? Are we throwing, are we skipping the wait 5-minute period between the thing and the next thing in the protocol and just throwing 1 or 2 darts at the board at the same time to see if we fix them, right? So it doesn't change the management, it just speeds it up.
Sorry, when do you consider BiPAP then? Is it below a certain, below how much for the SpO2?
There's no
Is there any values or-
there's no like gated number.
Okay.
I would consider BiPAP certainly if the patient is in type 2 respiratory failure, but it's also amazing at relieving symptoms in a lot of cases. So you can maybe even do it based on the patient's symptoms. You can see pretty easily if a patient is getting tired of breathing really hard. If they're visibly getting tired of breathing really hard, you should start considering positive pressure ventilation. Okay?
If between the nebulized bronchodilator and the BiPAP, how long should you wait in the similar situation?
So the weird part about Sim Wars is that you only have 10 minutes, and we want to see how much you know. So very rarely do we do the full weight of however long you want to wait. You know, whatever the protocol says, we very rarely actually follow that. We treat the patient's symptoms. So we give them the drug, we reassess. If they're not better, we do the next thing. Okay. You'll see sometimes people will skip you along. So if you're like in a situation and you've done something that's going to take 5 minutes, they're going to be like, okay, 5 minutes have passed, continue, and then you can do it. You never get to skip time. You just treat the patient as if you would treat the patient. The evaluators will skip time. Cool? We need to move. We need to hurry. All right. COPD, reactive airway disease, sometimes just chronic bronchoconstriction. What are 2 types of COPD? Emphysema and chronic bronchitis. Very good. What is the differentiation between the two? There you go. Pink puffers and blue bloaters. Good shit. Google that if you don't know what that means. Pink puffers and blue bloaters. Classic. All right. So these patients tend to be characterized by dyspnea distress. Their history lines up a lot with maybe an asthma history and an acute exacerbation, right? But they're going to have the difference of like telling you that they have COPD. You don't just like get COPD one day, right? You don't show up and be like, oh man, I got COPD. Like it happens over a long period of time. That's what the C stands for, okay? These patients tend to be barrel chested. There's your pink puffers, your blue bloaters, aspirates and crackles. They will tend to be hypercarbic, like at rest. They will have too much carbon dioxide at rest because their diffusion ability is bad. They will also tend to be hypoxic at rest. We shoot for an oxygen saturation of 88 to 92 in these patients. That is one of the times we want to consider staying away from high flow oxygen. Other times there's situations like stroke and MI where hyperoxia can actually cause problems in the reperfusing tissue. Okay? You're looking at me like I'm crazy. What's up?
No, I was just wondering because if you're like in a like really acute situation, is this something like you in like a shorter period of time?
No.
You care whether or not when you just give them oxygen?
No, give them oxygen. Yeah. If they're like super fucked up, give them oxygen. If they have something wrong with them that's not the COPD, give them oxygen, right? COPD patient comes in like status post-trauma with like an amputation. Give them high flow oxygen. You're not like, oh man, well, sorry about your leg, but you have COPD. Like, you're not using the fucking oxygen. Like, give them oxygen, right? The hypercapnic versus hypoxic drive thing, Jayton's absolutely right. It tends to be a little bit longer term. However, we do want to see you thinking about stuff like that in Sim Wars, right? So if you're saying, oh, let's get this patient on oxygen, let's say we'll titrate their oxygen to an appropriate level. Now, if they have an acute problem, maybe we're going to skip that. But if it's just a COPD exacerbation, titration is okay. Okay? All right. Diagnostics, pulse oximetry, end tidal cap. When we care about COPD, especially in the emergency setting, we want to know why are they exacerbating. So this is when we start thinking about infectious exacerbation. Want to look at blood cultures, want to look at full blood count to see white cell count, right? Versus all this other shit. Sputum culture could be indicated. This is a great COPD x-ray. What do we see in this x-ray?
Diaphragmatic flattening.
Yeah, flattening of the diaphragm, big fuck off lungs, right? Huge, massive lungs. Just filling up the whole chest cavity. That's because they're just retaining air in there. And it just over a long period of time, just big, right? So we see this angle here, way less than we see in a typical patient. Massive fuck off lungs. There's your COPD, right? So we see hyperinflation. We might see bullae. If you guys are able to see bullae on a chest X-ray, more power to you. And you may see pneumonia in an exacerbation, right? COPD exacerbation, you may see patchy infiltrates. You may see lobar pneumonia. Those things often come hand in hand. Anything on the ECG? Not really. All right. Treatment, same thing. Ventilatory support, oxygen, CPAP, BiPAP. Look at this. It's the same fucking protocol. Asthma, COPD, bronchospasm. The one thing I'll add is we want to consider if they have an infection. And if they have an infection, then we're treating that infection with antibiotics. Cool. We're gonna just buzz on here because we need to get to team training. Pneumonia. We all know what pneumonia is, hopefully, at this point. Everybody good? Great. So, what kind of pneumonia can you have? You have interstitial pneumonia. You have your lobar pneumonias. You have bronchopneumonias. So then you can break those down further into whether they got it in the community or whether they got it in the hospital, right? Perfect. Okay. What is that going to steer? CAP versus hospital-acquired or iatrogenic pneumonia? It's going to steer what antibiotics we're using. That's all. And what are we going to say when we are asked what kind of antibiotics we're using? We're going to say we're following our local guidelines, baby. So we just get our little antibiotics app out. We look it up. If you want to know shit the way we do it in Ireland, like you're welcome to know it for SimWords, but I'm fine with we'll consult our local guidelines for antibiotics, right? Or we'll consult with pharmacy for antibiotics. Because wherever you go, those guidelines are going to be slightly different, right? So these patients, what's the big differentiating factor with our pneumonia patients? To differentiate it from CHF so you don't do the stupid thing and diurese these people? Productive garbage cough. What else? Fever. Great. Okay, so this is infectious, right? So we're probably going to have some signs of infection. Fever, cough, can be pleuritic chest pain, tends to be more like dull pleuritic chest pain. So like, oh, it's sore. When I take a breath in, it's worse. Coarse crackles, great. Tends to be inspiratory crackles because that air's like bobbing through all that garbage. Cough, productive of green or yellow sputum. Not always, obviously. Can be rust-colored in... There you go. There you go. Fucking stuff questions coming out. Can be rust-colored in strep pneumonia. Good. What other things cause pneumonia? You got some out there? Legionella. Okay. Yeah. Fuck yeah. All right. So what's our Legionella one gonna be? What's our? I don't care about that. What's our patient gonna complain of? We're talking Legionella pneumonia. Okay. Could be immunosuppressed. I'm talking about symptoms. This is not stuff you have to know for SimWords. Yeah, so Legionella tends to bop along with like diarrhea. You'd be like pneumonia plus diarrhea, right? Yeah, doesn't matter. Doesn't matter. Anyway, pneumonia. There we go. Okay, so check this out. Tell me what's wrong with this chest X-ray. Lobar pneumonia. Great. So look, it's fucking bad, but it's in a lobe. Perfect. All right. So pulse oximetry, end-tidal cap, COVID swab. Never forget it. Bloods, ABG, UNE, full blood count. Blood cultures. Can do sputum cultures as well. If you're like, we don't know what this is, odds are you'll figure it out pretty quick. Chest x-ray. There you go. There's your chest x-ray. How do we manage? Ventilatory support. Oxygen. Hemodynamic support with fluids. Sepsis 6.
Oh, yeah.
Tell me the sepsis 6.
Give
3. Take 3.
Give.
What are the 3?
Antibiotics.
Antibiotics, oxygen,
Fluids.
fluid resuscitation. Perfect. So sepsis 6. Give antibiotics, oxygen, fluid resuscitation. Take blood cultures, lactate, urine output. Fantastic. Good stuff. That is going to come up 1,000 times. Okay? So you know that shit like the back of your hand. And this is one of our ways we can get sepsis, especially in our older populations. So pneumosepsis, very common. Antibiotics, per local guidelines. Over here we got a little CURB 65 score. Everybody know the CURB 65 score? Popped up? Okay. CURB 65 is a good scoring system, and this is more useful in your real life than in SimWords because SimWords patients, again, tend to be really bad. But CURB 65 is a scoring system we use to predict out-of-hospital mortality for patients that present with pneumonia to the ER, community-acquired pneumonia, right? So our patients with scores of 0 to 1, we can consider low risk, and we can treat them at home with an oral antibiotic. 2s are kind of our borderline, and then any with 3 or higher is treated in hospital with IV antibiotics, right? It's a really simple scoring system. Looking at 5 factors: confusion, looking at their urea level, their respiratory rate, their blood pressure, and their age. It's like the stuff you think about when you're like, oh, is this patient going to die? Like, are they old? Are they breathing super fucking fast? Is their blood pressure really low? Are they confused? And then like, how much urea do they have? I don't know. That one's out there, but it works. So a couple rare things, and then we're just going to break it. Pneumothorax, buildup of air in the thoracic cavity outside the lungs. Okay, what do these guys present as? Spontaneous pneumothoraces. What do they present as? Tall, lanky boys. Sudden onset. Shortness of breath. Sometimes smokers, not always, but yes. More likely if they're smokers. Sudden onset, shortness of breath. Pain. Shortness of breath, pleuritic chest pain, risk factors, tall, thin, males. Opposite of DVTs. Right?
Yeah.
Good. Okay. So, how do we diagnose this? Yeah, fucking listen to it, bro. Listen to it. Why did it double? It doubled for some reason. All right, listen to it. That's just the one. We're going to talk about that. I want you guys to remember that because that's one that people get caught up on a lot, is we'll get this, and we've said it 1,000 times. People show up to SimWords, they're like, We need a chest X-ray. Diagnosis pneumothorax. No, you don't. You can use your eyes, you can use your hands, you can use your stethoscope. So what are our physical exam findings in a pneumothorax? Whether it's spontaneous or trauma-induced or whatever, what are our exam findings in a pneumothorax? Hyperresonance to percussion, unequal chest rise, decreased air entry on auscultation.
It's really severe tracheal.
Okay, that'll kill you. But yeah, tracheal deviation. So anytime we start thinking about tracheal deviation, we're talking tension pneumothorax and we're talking late tension pneumothorax. Dying in 5 minutes or less. Money back guarantee. Okay, so don't look for tracheal deviation as your first indication the patient has a pneumo. All right, I just want to cover this real quick because it gets missed all the time in the scenarios that we're about to do. Not that I'm saying there's a pneumothorax in there, but sometimes there is. Because we think, oh, we need a chest X-ray to diagnosis. We do not. Uneven chest rise. If you want to have a fast, yeah, absolutely. I will tell you that if you diagnose a pneumothorax, especially a tension pneumothorax on fast, you have already missed something in your exam, right? So if you get to that and you're like, oh shit, there's no lung sliding, that's new, and I didn't know that I was going to see that already, you fucked up somewhere. Because you missed another finding. Because by the time when you see no lung sliding, you already should be hearing decreased air entry, feeling that unequal chest rise, maybe increased resonance to percussion. Okay.
So can't you order a chest X-ray? Like if you're.
I absolutely want you to order a chest X-ray,
Okay,
but I want you to know what you're going to see on that chest X-ray before you get it back.
Okay, but do you need to treat, like if it's a tension pneumothorax, are you supposed to get the chest ring before?
Yes, absolutely. If you're confident that there's a tension pneumothorax. Spontaneous pneumothoraces very rarely escalate to tension. I don't think it's almost impossible for spontaneous pneumothorax to escalate to tension. But in a situation, maybe a trauma situation, where you have a tension pneumo, you have that pneumothorax, you have no air entry on that side, hyperresonance to percussion, unequal chest rise and fall. Absolutely, I want you treating that before the fucking chest X-ray. Right.
Are there ever any situations where you don't do chest drain for spontaneous pneumothorax?
There are absolutely situations where you don't do chest drains for spontaneous pneumothoraces, right? So I think the cutoff criteria is like less than 2 centimeters of air gap. I'm not 100% sure on that, so don't quote me on that, guys, online. But I believe the cutoff criteria is less than 2 centimeters of air gap is defined as like a small or low-risk spontaneous pneumo. Those often resolve on their own with high-flow oxygen. Right? Because one of the things that high flow oxygen does is it like decreases the osmotic component of nitrogen, which like sucks the nitrogen back out of the thoracic cavity. I don't know. It's fucking weird pathology science that I don't understand. But long story short, put them on high flow oxygen, the nitrogen will leach out of that area. Nitrogen's 78% of the air that's in there, so it'll
10 minutes similar scenario. Are we just gonna, is it always gonna be chest drain scenarios?
You're very rarely gonna see one with like a small pneumothorax, yeah. Now you might, but we'll talk about that in scenarios. All right.
How do you know, like, if you need to put, well, no, I guess if it's tension pneumo, you have to treat it first. But if it's a spontaneous pneumo, do you first need to wait until you get the chest?
So if it's a spontaneous pneumo, and the patient is stable, right? So you look at this patient, they have an okay oxygen saturation, they're not hyperventilating, they don't have crazy physical exam findings, you may wait for the chest X-ray. In a situation where the patient is unstable, that is treated immediately. Okay? I saw your message. All right, we're done. Scram. Oh, there's feedback form. If you have feedback, send it to me. I know this stuff is down and dirty. It's real fast. We'll get in more in detail as we go on throughout the year. I'm just trying to lay down the basic foundations of what we're doing here, okay? And if you go out there in the world and some RCSI person tells you that what I taught you is wrong, just be like, okay. All right?
Okay. So, we have a room. It is, however, in 123, tier 5. You guys remember last year when like no one could find the
Oh, up the stairs.
Thank you all.
Yeah.
See you later.
Bye. Thanks.
Have a good one.
So Lucy's over there with our patient actor.
Okay, let's go.
And